I would now like to hand the conference over to your first speaker today, Mr. Michael Schulner. Sir, the floor is yours.
Thank you for joining us for the COVID-19 media call for September 16th. We'll start today's call with a situation report from Minnesota Commissioner of Health, Jan Malcolm. We'll also hear from MDH Infectious Disease Director Chris Ersman and State Epidemiologist Dr. Ruth Field. After that, we'll open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everybody. I'll be brief today. As of this morning, around the world, we were above 29.6 million cases and 935,000 deaths. The United States now has more than 6.6 million cases of COVID-19 and 195,000 deaths. Of COVID-19. This is up 513 on a testing volume yesterday of 9,910. So we continue to see what's now sort of a familiar pattern of lower testing volumes coming out of the weekend, building up through the rest of the week is our typical pattern. We are reporting 7 additional deaths today, bringing us to a new total of 1,933 of our fellow Minnesotans who have died from COVID-19 disease. 2 of these persons were in Hennepin and another 2 in Ramsey counties, 1 each in Anoka, Nobles, and Winona counties. 1 person in their 100s, 2 in their 80s, 3 in their 60s, 1 in their 50s. 3 of these deaths were among residents of long-term care facilities. I'll note that for today's web posting, we're reporting 7 new deaths, but the total cumulative count goes up by 6 because a death previously reported earlier this summer has been removed today. Upon further review, it was determined that the death was not due to COVID-19 and is so noted on the website. The hospital situation remains quite stable. As we've said a number of times, our hospitals around Minnesota, particularly in the metro area, are quite full, but not with nearly as many COVID patients as we had seen in the late spring. 244 patients are currently hospitalized for COVID-19, 136 of them in intensive care. As you know, we track closely the test positivity rate using a 7-day rolling average for that number and factoring out the last 7 days, which we consider to be a lag period during which data are still coming in and need to be verified. So the 7-day rolling average test positivity rate as of September 7th, prior to the lag period, is 4.8%. So we've now seen several days with the rate below 5%, which is a critical threshold that we watch carefully, that we consider a 5% test positivity rate to be a real caution indicator. And that's certainly an indicator that's widely tracked nationally as well. In terms of volumes, as of yesterday, total testing has increased week over week by 6.4%, whereas new cases are increasing over that same time period by 4.8%. So again, that is a ratio that we like to see in that direction, making sure that we are testing adequately and finding fewer new cases among that larger testing volume. If that ratio will reverse, we would be strongly believing that we were not testing adequately to find all the cases that are out there. I just will make a quick comment before handing it off to Chris Ersman that we're certainly watching with concern the rapid growth in cases that we're seeing in some of our neighboring states. And given that we are still awaiting to see the potential impact of Labor Day, schools and colleges coming back into session and the like, while we're very grateful that our numbers have been fairly stable of late, just want to again remind everyone that if we see some of the same impacts after Labor Day that we did from July 4th, we may be anticipating seeing some increased case numbers in the future. And just again, call for continued vigilance on all of our parts to continue to take this virus very seriously. With that, I will turn it over to Chris Ersman.
Thank you, Commissioner. I just want to note, give you some updates on our county case rate data. We will be releasing new 14-day COVID-19 case rate by county data tomorrow for school districts to use in informing their decisions on what learning model to implement. And some counties in Minnesota may see a rate decrease for the most recent 2-week period. We want to re-emphasize that the overall trend of the data is more important than the actual most recent data point. So in other words, are the cases trending up or down in our area? It's also to keep in mind that the most recent data point will not account for disease spread that may have occurred during Labor Day weekend or the first few weeks of school. We have seen increases in cases following other holidays, but case rate increases take a couple of weeks to show up in the data. We're advising school policymakers to continue to be cautious in their decision making. Then I want to acknowledge that today CDC provided states with the 57-page playbook that they have been promising us to assist us with our COVID-19 vaccine planning. Our state plans are due 30 days after we receive the playbook, so on October 16th. I do want to acknowledge that the document itself says that it is not known yet which vaccines will be available, in what volume, at what time, with what efficacy, and with what storage and handling requirements. So while this document will be very helpful to us, and we've been eagerly awaiting it, there is still a lot that is unknown and that it does not provide for us. Kind of the key concepts that the playbook provide for us are, first, that there will be 3 phases of vaccine rollout. The first is a phase in which we expect potentially limited supply that will focus on healthcare and people at risk for severe illness. Then the second phase would be when a larger number of doses are available, and we would start by ensuring that we had been able to vaccinate everyone identified in phase 1, and then start adding the general population. And then phase 3 is that point at which we have sufficient supply for the whole population. And throughout all of this, we want to make sure that we are making vaccine available in an equitable manner. Another one of the things that the playbook talks about is standing up a team to discuss COVID vaccine allocation. And certainly, I think we've talked about this before, that the federal government, through the National Academies of Science and the Advisory Committee on Immunization Practices, will be providing overarching guidance on prioritization for vaccination, but we will need to operationalize that for Minnesota. So we're bringing together a team with broad representation who can help us in this process of translating the recommendations we get from the federal government to help us address the unique challenges of providing vaccine in Minnesota. Just a couple of thoughts in general about this process and about all the many aspects of our vaccine preparation work. There's a big expectation and a big emphasis on making sure that we're reporting data to the federal government and federal health officials. And that is an important part of being transparent and understanding where vaccine is. But that also means that there will be a need for strong IT solutions, and we're waiting to get more information on that from the federal government. So that is an area that has yet to be developed. And then, as I mentioned, we don't know which vaccines will become available, and there are multiple candidates in various stages of clinical trial review. And so that means that this process will be infinitely more complex than any of the mass vaccinations that we've done in the past, even H1N1, because we'll have multiple different vaccines with different storage and handling guidelines that cannot be interchanged, that may need adjuvant in some cases, that may have different intervals between 2 doses. So lots of different elements. So just want to acknowledge that even as we are eagerly planning for vaccination in the future, I want to acknowledge complexities, as I said, related to IT solutions, related to just what type of vaccine will be available. So as we move forward, we are working to do, the best that we can in terms of logistics, and we'll continue to look forward to more information from our federal partners. But needless to say, our vaccination process, it will be a complicated one, and we'll do our best to continue to provide you with information as we learn it, so that you too know what to expect as we anticipate a vaccine for COVID. And with that, I'll turn it over to Dr. Ruth Linfield.
Thank you very much, Director Erickson. And I am going to speak with you today about a couple of things. The first thing I'd like to talk to you about is a toolkit that is now available on our website for healthcare workers, which provides mental health resources. As you can probably imagine, healthcare workers often work under stress, and the current moment is surely not an exception. In fact, more than ever, it is really important for leaders in the healthcare field to support healthcare workers' mental health and well-being, both in and out of the workplace. MDH worked in partnership with CDC to create a toolkit of mental health and resiliency tools for healthcare workers. This toolkit aims to increase leaders' understanding about common healthcare worker concerns and anxieties, illustrate ways that leaders can address these concerns, promote self-care among healthcare workers, and increase healthcare worker access to mental health support. The toolkit includes a series of fact sheets, resource guides, and supplementary documents designed to empower leaders to support their workers and help workers manage their own stress. All of the resources are available on our Mental Health and Resiliency Tools for Healthcare Workers webpage. We are extremely grateful to our partners working to provide care for patients in all kinds of healthcare settings, from emergency departments to intensive care units, to acute care, to long-term care. These professionals have been working under extremely intense circumstances for months. We hope providers can use these resources to help promote the importance of supporting healthcare workers' mental health and well-being. Now I'd like to talk about the Casper Survey. This week, we began conducting a statewide COVID-19 survey of Minnesota households. Many of you have probably heard about it already. It's called a Casper, or actually modified Casper survey. Casper stands for Community Assessment for Public Health Emergency Response. These types of surveys are an evidence-based tool developed by CDC to collect household information during public health emergencies. They have been used after events like hurricanes, oil spills, and even the Zika virus outbreak. The goals for this particular Casper study are to learn more about how COVID-19 has spread in Minnesota communities, to learn more about what caused COVID-19 to spread in certain areas, to learn more about how COVID-19 transmission and infection rates differ among regions in Minnesota, to learn more about the percentage of people infected with COVID-19 who did not recognize symptoms or had no symptoms, and to improve health messaging and help stop COVID-19 spread. Since this is a new virus, we have to learn as we go. Information we gather will be used to help us inform our response going forward, and will add to our understanding of COVID-19. The survey is taking place from September 14th to September 30th. During that time, teams of public health professionals will visit randomly selected households in 180 pre-selected sites around Minnesota. The sites were selected using a sampling method that takes into account population size. Households were randomly selected within each site. The survey teams wear a bright and colorful vest with a label showing they are part of the COVID-19 survey team. They also wear masks. The teams consist of public health workers and healthcare providers. So the team will have one of each. The survey includes a household questionnaire, and all members of the household are offered free COVID-19 testing. The testing includes a nasal swab to see if the person currently has COVID-19, as well as an antibody test to see if someone has previously had COVID-19. After agreeing to participate, one member of the household will complete a questionnaire. While conducting the survey and the test, the team will wear masks, gloves, and gowns to help keep all participants safe. Participation is completely voluntary, and households can participate in all or just parts of the survey. All information will be kept private. There are lots of opportunities for people to get tested around the state, but this type of study and testing in general is different. This type of testing is called surveillance testing. The testing that most people seek is because they have COVID-19 symptoms or they were exposed to someone who had COVID-19. And that is an incomplete representation of COVID-19 spread or presence in Minnesota, because people can get COVID-19 but not have any symptoms and may not be aware of a contact from which they had virus transmitted. With this type of study, though, we are able to learn more about how and where COVID-19 is spreading in our Minnesota community. We really hope that people will participate if these teams knock on their door. By participating, you can get the free COVID-19 test, but from our perspective, really important, can contribute to what is known about COVID-19 in Minnesota and help slow the spread of COVID-19 by helping us understand what prevention strategies and messages work best. And it also provides an opportunity for you to share your concerns or to ask questions to the team. We've talked about the rise in cases. We really need everyone to do their part to reverse the trend. Research like this gives us another window into how COVID-19 is spreading in our state and the actions we can take to slow the spread. At this point, I would like to turn the call back to Mike Schomer.
Thank you, Dr. Linfield. Operator, we are ready to take questions.
Thank you. Ladies and gentlemen, as a reminder, to ask a question, you will need to press *1 on your telephone keypad. Once again, *1 on your telephone keypad. Your first question comes from the line of Jeremy Olson from Star Tribune. Your line is open.
Hi, I wanted to ask about today's MMWR report on the elevated rate of stillbirths and preterm births, and also hospitalizations for pregnant women, if especially if they had diabetes or obesity. That there was an elevated rate of COVID-19, that COVID-19 elevated the rate of hospitalizations and also preterm births and deaths. I just wanted to get your reaction to these findings. I know you've been tracking COVID hospitalizations among pregnant women, so maybe you have some information or reaction to this new data.
Ruth or Chris, could either of you take that, please?
Sure, I'd be happy to take that. Oh, you can, Chris. I mean, we participated in that study. It's part of COVID-net. But go ahead. please.
Well, I was just going to say that we do have, I do have some data on our pregnant women in Minnesota through August 31st. So perhaps if Ruth wants to comment, and then I can just provide some follow-up data.
And just to be clear, the COVID net data is separate from today's study, which was in the MMWR, which was reported by a separate group of 9 clinic groups.
Okay, so go ahead, Chris.
Okay. Oh my goodness, the politeness of back and forth. All right. So in Minnesota, if we look at our data through August 31st, we had 23,167 women of childbearing age. And so that represented roughly 30% of our cases. And childbearing age is defined as 15 through 44. And of those women, just over 4%, or 999 women were reported as pregnant at the time of infection or specimen collection. And so when we look at our data, what we found is that there were 198 women who were hospitalized after or at the time of their COVID positive test. So that was about, because of the nearly 1,000, it makes it 19.8% of our pregnant cases. 18 of those, or 9%, were admitted to the ICU. There were 2 fatalities. However, one of those deaths did not necessarily occur at the time of the COVID infection. And when we look at the complete data, in other words, women who have gone through their pregnancies, and we can look at birth outcomes, we have data for about 25%, or 246 of our pregnant COVID positive cases, and they had 261 birth outcomes, with obviously some women having multiple children. And in that group of that 261, 256 were live births, so 98% were live births. 2 were stillbirths. There was 1 termination and 2 miscarriages. And so when we look at the data, in terms of our data, we're seeing the majority of the pregnant women having a positive outcome. We also looked at, the infants and whether or not there was, premature delivery. We had, of those 256, with complete data, we had a few children, 36, who were admitted to NICU, 21 for prematurity. But then the others, multiple different reasons. And just want to acknowledge that the premature births that we did see, that 8.5%, that was equal to the national average of premature birth. So we've seen, obviously, we have data on our cases. Our cases, the outcomes that I gave you were not, looked at by race, ethnicity, but we're not surprised by what's being described because we've seen that with our other cases. Perhaps that was too much detail, but.
That was terrific. Thank you. I had a second question. I'm sorry, I had to ask one for my sports guys, but they wanted to get reactions from someone at the health department on the Big Ten moving closer towards resumption of sports or of athletics this fall, and also the state high school league making overtures or steps towards the resumption of football and volleyball with a special meeting planned Friday. Both things seem to be happening or leaning towards happening. Wanted to get reaction and thoughts about whether that's a good thing.
Well, this is Commissioner Malcolm. I'll start. Certainly invite Ruth or Chris to comment as well. We've appreciated the high school league's careful thinking and attention to this. They've asked for input along the way, and we've given them, shared with them, what data we have about the impact of sports on case transmission with Minnesota data over the summer. So just in general, I'm sure it won't surprise you to say we're always concerned about things that just increase close contacts of large numbers of people, given the degree of virus that we know is circulating in the community. Certainly, we know that we continue to say that outdoor venues and outdoor sports are appear to be less risky than indoor sports, but high contact sports just do have a risk. And of course, we're concerned about not just the games and the sports themselves, but the socialization that comes along with that. So I think if indeed we start to see more of these kinds of athletic events, it's just going to be extra important that everybody be aware of the risk and really pay close attention and comply with social distancing and mask wearing guidance.
Thank you.
Thank you. Your next question comes from the line of Catherine Rickert from Minnesota Public Radio. Your line is open.
Sure. So we have two presidential candidates visiting Minnesota this week, President Trump and Joe Biden. And I know the governor has written a letter urging them to follow crowd size and mask guidelines. What if that doesn't happen, and what sort of conversations are you having right now with the campaigns to ensure that it does?
Well, I think the governor sent that letter yesterday, I believe, or not sure if it was last night or this morning, but we thought it was important. He thought it was important to just make that statement and let them make sure that the campaigns knew what the capacity guidance was in Minnesota, and that is our strong hope and expectation that be respected. I'm not aware of any specific conversations between the health department and the campaigns, other than just we're certainly available to answer questions if they have any.
Is there anything that happens if they don't follow those guidelines?
Well, I think, as we've seen with all kinds of events, we just keep on reinforcing when we know events are planned that the event organizers are aware of those activities. And I would need to defer any questions on enforcement actions to other authorities.
Okay, I have a follow-up question on a different subject. I know that the state has been involved in a lot of very targeted testing efforts, so pop-up testing clinics targeted at different geographical areas, but also at specific communities, immigrants, people who don't speak English as their first language, that sort of thing. And I guess I'm just wondering, broadly, why is it so important for the state to be targeting specific groups in testing, particularly those who might be new to the United States or not be from here originally?
Commissioner Malcolm, again, I'll start and welcome additional comments from my colleagues. And I think we've talked a lot about the fact that we know that the burden of COVID is falling disproportionately on different parts of our community, on different communities based on their occupational exposures potentially, their housing situations. We also know there's differential access to healthcare and to testing, and that where the health systems have been really the bedrock of a lot of the diagnostic testing that's happened, but for various reasons, that testing resource has been less utilized by some populations, again, partially perhaps due to insurance status or just unfamiliarity or discomfort with the systems. So we think that these community-based testing events that are done, in partnership with trusted community organizations, helping to get the word out, helping to encourage people to attend, is just important to really offer those resources to groups that we know have some higher risk levels for exposure and potential for transmission, and have been under-tested to this point, according to our data. But Chris, Ruth, anything you'd add?
No, I think you said it well. I mean, these are groups that we know that are at greater risk for COVID because of a number of factors, as well as at greater risk for complications. We want to make sure that they can be tested and identified as having disease as quickly as possible to prevent additional spread.
Okay, thank you.
Thank you. Once again, if you would like to ask a question, you may press star one on your telephone keypad. Your next question comes from the line of Paul Scott from Forum News Service. Paul, your line is open.
Hi, thanks. So I hear that you haven't made contact with the president's campaign about how many people they're going to let on site in the Bemidji, but do you plan to monitor the event? Hello?
Commissioner, are you on mute?
Oh, I was indeed. Thank you very much for the reminder. Yes, we work with local public health colleagues around the state, and certainly our local colleagues up there are well aware of the event, and will be, I'm sure, and maybe having conversations that I'm not directly aware of with event organizers up there. But we just wanted to make it clear what the current state guidelines with respect to crowd size are, and to really ask the campaigns, as I think the governor's letter did very well, to just partner with us and really lead by example.
Great. And just to follow up, do you know how many people attended the Mankato visit? That was also on an airfield. Was it within the limits in your recollection?
You know, that's a good question. I don't know that. I don't know if Chris, if you have any either data or recollection of that.
I'm sorry, I don't, and I'll offer Ruth a chance too, but I'm guessing we've had our noses in COVID too long.
Yeah, I don't. Sorry.
Okay, thank you.
Thank you. And we have a follow-up question from Jeremy Olson from Star Tribune. Your line is open.
Whoa, I wasn't ready. Thanks. One of the listed reasons on the Casper website for doing this study, at least it was, I think it's listed there, is that it can help inform modeling for ongoing predictions of COVID prevalence and spread in Minnesota, which implies that there is modeling going on. There have been some hope to produce an updated model in May or August, but now in September. Can you tell me how will this help with modeling efforts? And two, can you verify, is there going to be an updated model produced by the health department and the University of Minnesota on COVID spread?
I'll ask Ruth to comment on anything more she can add on this from the study perspective. But so yes, the university model is has been being worked on, as we've said several times, with some different updates to the model, different improvements to parameters and assumptions and so forth based on more Minnesota data. Just had asked that question in the last couple of days, and have been told that they're getting close to having something. The university is getting close to having something that they can review with us. I'm sorry, I can't be more precise, but I can certainly confirm that the work is in progress, and we are expecting an update in the fairly near future. I guess I'll just say, and the ways in which the Casper survey could inform that, I think that and I'll also just say the university model is certainly one thing that we that have been informed by over time, but there are also 30-some national models out there that also do projections on Minnesota. The CDC does a kind of a composite model based on some of the more high-quality models. So there are a number of different models that are being looked at and are informing us. So I think all of those models have in common the fact that they're highly dependent on the assumptions that they use about things like behavioral changes like social distancing, limitations on social interactions, mask wearing, etc. So the more we can learn about compliance with those things, the more that helps to inform the model's assumptions. Ruth, anything to add there?
Thank you, Commissioner. The only other thing I would add that will lend some insight is there is a seroprevalence component, and so it may give us a sense of how many people have been exposed to COVID-19 in different parts of Minnesota? Thank you.
Thank you.
Thank you. Once again, if you would like to ask a question, you may press star 1 on your telephone keypad. Speakers, there are no more. Oh, we just got one from Paul Claudia, Minneapolis Star Tribune. Your line is open.
Thank you. Just a follow-up to Jeremy's question on our behalf about the high school and college sports situations that are developing in Minnesota, with the Big Ten planning to start football and the high school league at least planning to meet Monday to talk about volleyball and football restarting. And if I could put a personal spin on my question, if your family included a high school age volleyball or football player or a college age football player living with you, how would you feel about their school team starting up playing their sport next month, and what would you advise them to do?
Well, I might defer to my colleagues who actually have kids as well. So that's perhaps not a fair question for me to punt to them, but in terms of advice to parents, I think they have a qualification I lack. But certainly, just to reiterate the point that we know that these are complicated decisions with lots of good reasons why people are eager to have those activities available. But definitely we are very concerned about kind of the social activities that come along with the games. The games themselves, we think, do carry a level of risk, especially for high contact sports. But we just really, again, want to reinforce the importance of complying with those the health guidance for people who are participating as participants or spectators, and really being mindful of the kind of the other social activities that can come along with the resumption of those athletics. But Chris or Ruth, anything else you'd want to add?
Well, this is Chris Ersman. I'll add just a couple things. One is that when I used to talk to my kids about things, sometimes I would say I'm putting on my mom hat or I'm putting on my public health hat. And so I'll say from my mom hat that the sports that my kids participated in and the ability to be involved and be a part of that were some of the happiest times of our high school time together. And so I absolutely feel for the parents that feel so strongly about this, because I know that for our family, it was really such a significant event. So that's my mom hat, and my mom hat gets kind of choked up talking about it because I know how significant it is. But then if I take that hat off and put my public health hat on, right now, if we look at our data, we have 1,452 cases. This is as of September 9th, that have been associated with sports activities. And those cases, and that does include cases in adults, 888 cases in adults. But when we look at what that means for just household contacts that were recommended for quarantine, that's 3,348 people who were recommended to be quarantined as a result of these cases. And if we look at them, by where we're seeing the clusters, we've had 62 outbreaks or clusters. 15 have been associated with basketball, 9 with soccer, 9 with hockey, 9 with football, 6 with volleyball. So the public health hat, when I have that on, I recognize, what we're seeing with disease transmission, and that is really concerning. And I know Ruth's a mom, and she has hats, so I'm going to let her comment as well.
So thank you, Chris. And thank you, Commissioner. I think you both articulated the issues very well. It's a complex issue, and I think we need to be mindful, and we need to continue to weigh how much viral activity there is in our communities, and what are the activities that we're doing. You know, this is not a cold. There are some people who do fine with this, but there are others, including young people, who don't do fine. And along with the sports, you know, there are coaches, there are other people who may have underlying conditions, and it would have a severe illness if they were to be infected. And we're only beginning to learn about potential complications that occur in young people. There was a report out of Ohio looking at college athletes and the occurrence of myocarditis. And so we really don't have a sense of what all the things this virus can do. And we just have to be aware.
Operator, we have time for one more question.
Thank you, sir. Once again, if you would like to ask a question, you may press star 1 on your telephone keypad. Speakers, if there are no more questions at this time, you may continue.
All right. Well, thank you to everyone for joining us on today's call. If you have additional questions, please feel free to reach out to our communications office this afternoon. Have a good day, and we will be back with you again tomorrow.
Thank you, Speaker.
That was state health leaders with the latest information on COVID-19.